Hi, and thank you so much for tuning in to this part two of two in a webinar series focused on urinary incontinence in women. In this section, we'll be focusing on digital health and the opportunities within digital health for urinary incontinence. We'll take a specific focus on first-line care and talk about both current practices and new opportunities. I'm Dr. Jessica McKinney. I am a physical therapist and the VP of Medical Affairs and Clinical Advocacy at Renovia Inc. And I'm joined by my colleague, Dr. Laura Kaiser, a physical therapist who also holds a public health degree. She's our Senior Manager of Medical Affairs at Renovia. I'll leave this slide up for a few moments to draw your attention specifically to the fact that these slides are intended for healthcare professional and provider reference materials only, not constituting medical or clinical advice. And then on the lower half of this slide, drawing your attention to the indications of the Leva pelvic health system. It's intended for strengthening of the pelvic floor muscles and rehabilitation and training of the pelvic floor muscles for the treatment of stress, mixed and mild to moderate urgency urinary incontinence, including overactive bladder in women.
Great, so I'll pick it up here. So our objectives for part two are listed here on the slide. We want to provide a little bit of a background and overview of sort of the public health approach to tackling some problems like urinary incontinence. And then we'll look at digital health, kind of broadening perhaps your understanding of what digital health encompasses. And then how that can be applied in the context of urinary incontinence. And then Jessica will introduce the Leva pelvic health system and get into some more details there. So when we think about population health, on the right-hand side, you see the health impact pyramid, and this was put forth in 2010 by Dr. Thomas Frieden, who was the former director of the CDC. And essentially he was trying to illustrate kind of how to have the biggest impact, the kind of the biggest bang for your buck in terms of various interventions at a population level. And so what you can see at the very top are things like counseling and education and the clinical interventions that we're very accustomed to providing. And then at the bottom, you see things like socioeconomic factors and changing contextual factors to improve health at a population level. And there's a great publication that came out somewhat recently about the evolving role of public health in medical education and medical care delivery. And the authors say, what the one patient at a time approach may be the appropriate mindset for diagnosing rare genetic conditions or uncommon malignancies, but it becomes inefficient and futile in a setting where there's predictable patterns of disease, and these are impacting millions. And we would argue, along with other researchers and clinicians, that female urinary incontinence is a public health problem that sort of warrants a population level approach to tackling it. So when we talk about the public health approach, essentially there's four primary steps that, and they're sort of cyclical because you begin with surveillance, but you also kind of end with surveillance. You don't want to you want to continue to be monitoring a particular health problem. So in this case, we have urinary incontinence. Once you've surveilled the kind of prevalence and incidence of a certain health condition, then you want to think about what are some of the risk factors and the protective factors and the various causes of this health condition. Then moving on from there, developing and evaluating various interventions. So what types of interventions work and for whom or for what types of patients. And then finally, implementation. So scaling up interventions, creating policies and programs and things like that to address the health condition. So when we think about female urinary incontinence from a public health lens, at the top in terms of surveillance, we have that data, which was presented in part one of this webinar. Over 20 million women with incontinence living in the United States, up to a 50% lifetime incidence of UI. We know what the risk factors are, pregnancy and childbirth being two primary risk factors, along with aging, obesity, constipation, smoking, functional status, and others, but those primary ones are listed there. We also know what treatment works, as Jessica did a great job kind of walking us through the care pathway in part one. We know first-line care for the three primary types of UI include pelvic floor muscle training and patient education, and that when done effectively, this can lead to about a 67% improvement or cure rate. So the question mark on the left-hand side there is, why have we not scaled things up? Why are we not implementing first-line care effectively? So I think when we actually outlined some of those in part one as well, and thinking about, why haven't we done it? Well, perhaps we don't have enough healthcare workers, and we need to essentially sort of build capacity in our health system to be able to treat so many women. And that's where digital health, I think, can play a role, really at every level on this health impact pyramid, but certainly in terms of scaling up and being able to provide care to more people who need it. So we use the term digital health as sort of an umbrella term. The graphic on the slide here was put forth by the Digital Therapeutics Alliance to kind of represent the various niches of digital health. So essentially, digital health is this umbrella that encompasses things like mobile health technologies, digital therapeutics, health information technology, devices, wearables, sensors, personalized healthcare, and telehealth or telemedicine. So all of that is included kind of in this digital health landscape. When we look specifically at urinary incontinence and female pelvic floor disorders, there is a fair amount of evidence to support the use of digital health and telehealth in this context. So there was a systematic review that was published last year looking at the role of telehealth specifically in rehabilitation for women with pelvic floor disorders. And particularly with regard to urinary incontinence and urinary symptoms, they found that there were significant improvements in these symptoms, as well as in quality of life and pelvic floor muscle function. And there was some suggestion that this was cost effective. Another systematic review looked specifically at telemedicine for urinary incontinence in women, and again found that, favorable results for the use of telemedicine, decreased severity of symptoms, and decreased symptom-related anxiety and depression were some of the key outcomes that they looked at, as well as improvements in quality of life, self-efficacy, and global impression of improvement. Additionally, another study in 2019 looked specifically at mobile technologies. So on the last two slides, we talked more about telerehab and telemedicine. This was actually looking at mobile technologies for self-management of urinary incontinence. And again, found good support for these types of interventions. So level 2 evidence, again, demonstrating improvements in symptoms, patient satisfaction, adherence to treatment, and costs. And then lastly, a very recent publication looked at evidence for the appropriate use of telemedicine in the context of female pelvic medicine and reconstructive surgery. On the whole, they found that FPMRS patients do own technology to enable them to participate in telehealth interventions, and for the most part, patients are willing to do so. These authors emphasize the role of patient education in terms of its importance in the context of urinary incontinence, and the role of leveraging telemedicine to improve and provide patient education, as well as remote pelvic floor muscle training, management of overactive bladder, as well as its use in terms of postoperative follow-ups for either uncomplicated urinary incontinence or prolapse surgery. So just revisiting the infographic that we presented in part one, you can see that on the left-hand side here. And really, again, just depicting that telehealth and digital health can be leveraged for various elements of this care pathway, including screening, preliminary evaluation, and initiation of first-line care.
Great, thanks. So now we're going to turn our attention to the Leva Pelvic Health System. This is Renovia's product. It is classified as a digital therapeutic by the Digital Therapeutics Alliance, very rigorous distinction for the product. And we're excited to tell you about how this is contributing to opportunities in digital health to help improve first-line care for women with urinary incontinence. So just as a reminder, we talked about this in our first section of this webinar, but we start by just remembering the definition of pelvic floor muscle training. So again, we've stated that this is the real keystone and cornerstone of first-line care. It refers to exercises for improving pelvic floor muscle strength, endurance, power, and relaxation. So different components of pelvic floor muscle performance, one or all of which may be targets of pelvic floor muscle training programs. There have been some challenges that we've talked about along the way in implementing the current care pathway in a way that is consistent with evidence. It's been, frankly, quite underutilized in terms of implementing pelvic floor muscle training in a supervised fashion, at least for women with urinary incontinence. And just a few of the things that are worth highlighting is that there are adherence and treatment challenges for carrying this out. Among a population of women who have pelvic floor disorders, only a quarter of them were performing pelvic floor muscle exercises on their own. And when the 25% of this group who said, yes, I'm performing my pelvic floor muscle exercises, I'm doing them, demonstrated those with an exam, only a quarter of that group was able to perform them adequately. So there is a benefit or a real need on the flip side for women to learn how to do an exercise correctly, but also to continue to get feedback on dosing of that exercise and their ongoing performance of the exercise so that it can ultimately yield the therapeutic outcomes that are desired. So the Leva Pelvic Health System is an FDA-cleared medical device. It combines hardware and a smartphone app. We mentioned at the beginning, but we'll reiterate that it is cleared for treatment of stress mixed and mild to moderate urgency urinary incontinence, including overactive bladder, and for strengthening of weak pelvic floor muscles. It's a Class 2 medical device authorized by the FDA through a 510(k) pre-market filing. The Leva Pelvic Health Program incorporates 4 components. Number 1 and number 2 comprise the Leva Pelvic Health System, the device that has an intravaginal component, movement sensors we'll talk about on forthcoming slides, and it pairs with the Leva app for guidance on exercise performance and monitoring of adherence and symptoms. But it combines with these other components to comprise the Leva Pelvic Health Program, whereby there is a Leva Women's Center care management team that will talk to women who have been prescribed Leva, talk about purchasing decisions, and very importantly, be dedicated to women who are using Leva going forward over a period of at least 12 weeks to provide a cadence of coaching and motivational support, as well as some technical and troubleshooting help to make sure they know how to use the product. And then lastly, this component 4 is a component whereby there's symptom and adherence reporting that is provided to prescribing healthcare providers. So there's several things that are unique about the product. First that we'll note here is the mechanism of action. So what we mean by that is how is Leva providing feedback on what the pelvic floor muscles are doing and if it's the right thing that they should be doing. So the wand is depicted in the 2 images from the left side, so the first 2 on the left. The portion kind of from the Leva section up is the part that is inserted. That is the same part that you see kind of in the side profile in the second image. Each one of those green dots is representative of a motion sensor called an accelerometer. These are very sensitive movement sensors that are embedded on a flexible wand. And when that is inserted, they communicate to the phone, and on the smartphone, it creates a composite image of the alignment and orientation of the wand within the vagina. So then what happens is as a woman performs her pelvic floor muscle training, she engages the pelvic floor muscles, she will see movement reflected on the screen that is consistent with the lifting and squeezing or angular motion that's produced during a proper pelvic floor muscle contraction. What we see on the center of this screen is just one view of some of the design features that are helping to to really target motivation and adherence. There are reinforcements and reminders, such as the 2 green check boxes that are depicted on the Tuesday and Wednesday boxes, showing that she has done her twice daily exercise program on those days and has only completed it once so far on a Thursday and has 1 more to do to earn the green checkbox. And as we click one more time, we're going to see that there is a video that starts playing here on the right-hand side. A woman is standing to do her exercises, and she gets this relaxation cue before she starts pelvic floor muscle training. The white line is following the alignment of the sensors in place. And here we see her doing a contraction. So she's doing a lift and a squeeze and holding that pelvic floor muscle contraction for a work period of 15 seconds. That's a challenging amount of time. And afterwards, she'll go back into this very focused rest session in between each repetition, where the focus is on relaxing the muscles fully so that the white line returns into a green zone, indicative of the muscles that can start at a baseline of being relaxed, contract, and then relax back down to their rest state. That repeats for 5 cycles. So there are 5 work cycles with 5 interspersed rest cycles to make 1 training session. And the app comes pre-programmed to do 2 of those on a daily basis. There are several instructional videos that support the onboarding, meaning just getting started with this process, and ongoing training. These exist within a video library so that a woman can return to them 1 or many times as she's continuing to work. As we said, the training is conducted at home or any place that is a comfortable and private setting for her. It's performed in standing, and the entire training program consists of about 2.5 minutes, performed twice a day. As we said, these are 15-second training sessions, 15-second rest sessions for 5 repetitions. And the Leva motion sensor, the term for the wand, is removed and cleaned after each training session and stored in its protective case. The Leva app is worth saying a few things, a few more things about. We've really taken an evidence approach, an informed approach to the design of the different features of this app. So from left to right, we see that there is a real focus on education, on how to do something correctly. What does incorrect look like? That is represented on screen. So if a woman bears down, for example, the purple line will not go to the left in this image. It would move kind of to the right into that pink or rose-colored section, indicative of somebody bearing down. And as we keep moving across, we can click to advance one more time, and we'll see the video play for us again in this training screen that guides her every time through her exercises. So again, that's the active rest period where she relaxes her muscles into that green baseline. And that's what she tries to return to after each one of these pelvic floor muscle contractions that she's holding. When that finishes, as we see reflected in the center of these screens, there's a session summary summarizing the average lift, so how many angles of displacement were accomplished and the average hold time. We see this home screen again, different ways to reinforce just a sense of like, am I making any progress? How am I doing here? And then the last of these is really worth mentioning. This is the symptom survey is how we refer to it within the app, but it is a validated tool, the Urogenital Distress Inventory, a 6-question questionnaire that targets bladder symptoms. Again, standardized and validated for this use. That is something she answers when she gets started in the program, and then answers on about a monthly basis thereafter, so that she is able to see, oh, I started with my score here, and this is how it's changing over time. And that is one of the really important metrics that comes through on the report that comes back to the providers that we'll see on a forthcoming screen. So the Leva Pelvic Health Program, like we said, is what we refer to when we've added both the Women's Center and these monthly reports. We've talked about how the Women's Center is staffed with coaches who support them from first call all the way through the end of their program. And then monthly reports that would come to you as a prescriber. So it is a prescription product that kind of starts in the office and under the supervision of the healthcare professional. And then information is returned to you on a monthly basis on adherence and symptom improvement. This is a quick look at the patient reports. As we said, the symptom survey, the urogenital distress inventory, is a 6-question survey that is one of the things that populates this report. It also will discuss her adherence. So if we've asked for twice daily usage, adherence is reported and reflected on that, including on a weekly basis. The amount of change that is happening over time on that UDI-6 is reported. And then we also use the patient global impression of improvement, another validated scale for change with a health condition in response to treatment. So that shows up on the report as well. So as we mentioned, I mean, we really are aware of several different types of shortcomings in pelvic floor muscle training, and sought about to try to understand what are the drivers of adherence and outcomes in pelvic floor muscle training, specifically for incontinence. And that's kind of foundationally identified as a process to adopt the type of health behavior change that is required to do exercises consistently and regularly, and to achieve that change in symptoms. It's based on a process that begins with awareness, proceeds with agreement to do something differently, adopting a new habit and adhering to that habit. So it's not just knowing what I should do and doing the thing. There really is a process for that. And so we've supported these different pillars of the components of that by doing passive data collection. People don't have to enter on their own if they've done the exercises or not. That's collected passively. We use validated surveys that are useful for both the woman using the product and to the healthcare professional to, again, build some awareness about, like, is this working? Like, how are we tracking it? How will we know if it's working and helping? We have individualized goal setting and ways to self-monitor progress, as well as condition-specific health education that is included in a very robust way within the app to help really foster that sense of understanding of why this program would be something that would work and getting people to participate in the process. We support the process further with several different visual cues that very clearly depict the right way to do things and how someone is doing. And again, the support of our Renovia, our Leva Women's Center team. And lastly, from adherence, it truly is helped by the ability to do these exercises really anytime and anywhere, and to customize both reminders and reinforcements. I want to say just a note here on our clinical development work. So at Renovia, I mean, we really are focused on and committed to a program of clinical research. It is a process, not a one-moment stamp in time. So we began with a relatively small proof of concept trial, just 23 subjects that had urinary incontinence, and really sought to see how they would have a change in symptoms in response to using Leva and training on a regular basis. And we saw a statistically significant improvement in that group compared to their baseline. And that, really started to inform our work to do more rigorous trials. So we conducted a pilot randomized controlled trial of 61 subjects that were using Leva at home versus a group doing pelvic floor muscle training at home, not under supervision. And again, we saw a statistically significant improvement in this group compared to the Kegel arm. You'll note that each of these have been published. We have a commitment to not only do good work, but to publish what we've done. And those are both available at the links that you see and in the journals that you see depicted. The next of these is a large randomized controlled trial that we have just completed. And this was enrolled about 350 subjects. And here we compared again the Leva with a group doing pelvic floor muscle training at home. We had about 300 that completed. They had stress or mixed urinary incontinence. If they had mixed, it was stress predominant. And they followed an 8-week intervention where we collected information at baseline, 4 weeks and 8 weeks. And we will continue to monitor them at both 6 and 12 months for follow-up. Now, this was an all virtual trial design. We started to plan this thinking it would be a traditional kind of brick and mortar design. But then COVID came to the world, and our switch to a virtual trial was really a part of that adaptation. And we're really excited for how that went and for those outcomes. So we published the methods of the paper in Contemporary Clinical Trials. You see that referenced in the mid part of this slide, and have submitted the manuscript of our primary 8-week outcomes for peer review. So we look forward to updating the world with those results when we can. We were thrilled to have principal investigators that have participated with us, many of them in other work as well. Dr. Holly Richter, Dr. Melina Weinstein, Dr. Naleli Guadarrama, and Dr. Gina Donovan. As mentioned, we collected top-line outcomes at 8 weeks. These include symptom improvement as measured by the Urogenital Distress Inventory 6-question questionnaire, which will document a % improvement, as well as stress urinary incontinence episodes as measured by the voiding diary. And lastly, I just want to make note, we mentioned this at the end of our first part, but our team has really worked along with others to synthesize information that's really pertinent to understanding risk factors and care seeking or care avoidance behaviors all the way through different phases of treatment, and synthesize that into an infographic that is available with a brief accompanying manuscript if you link the QR code and if you're interested in that. The infographic is available as a separate and downloadable high-res file if people want to use it. Our hope is truly that it would be a resource for colleagues and for patients alike to help better understand the totality of the process and to help improve access to treatment and ultimately outcomes and treatment access. So thanks so much for joining us. And we have been happy to share this information with you. So this brings us to the conclusion of part 2. If you missed part 1, hope you can find your way to it and check that out. You can reach either one of us at providersupport@renoviainc.com.